Hello, everybody. Welcome to our medical talk today with Professor Grünenfelder from Hirslanden, Zurich. Our topic today is the aortic valve surgery. And well, first of all, welcome and thank you very much for being here.
Welcome and thank you for having me.
So one of my first questions is that we would like to know a little bit more about the actual surgical procedure of an aortic valve surgery. Can you maybe help us with that?
Aortic valve surgery is very common. So we operate a lot of patients with the aortic valve disease. We have to distinguish between aortic valve stenosis, which is the most common one, having a calcified aortic valve, versus an aortic valve insufficiency, where the valve is leaking. But usually, the majority of the patients have aortic valve stenosis. And if we operate on these patients, usually they get a valve replacement. And we perform aortic valve replacement in our institution minimally invasively, meaning we don't split the chest bone for an aortic valve replacement. We do it through a small thoracotomy. It's called a small incision in the right chest, about 3-4 centimeters, to allow the valve to go in. But the rest actually is minimally invasively, is endoscopic assisted surgery with the help of the heart-lung machine, of course. We use for the routine standard aortic valve replacement, use a heart-lung machine to stop the heart. And this is installed in a minimally invasive technique through the groin. So we cannulate the vessels in the groin, and that's the way to install the heart-lung machine.
Just a bit for my own interest as well. How big is the aortic valve? Maybe what, a centimeter or?
That also depends on the patient, but we have usually measurements of 21 or 20 millimeters in diameter up to 30 millimeters in diameter. That's the normal range of aortic valves in our population.
So super small, actually, no? Very.
Yeah, it can be small.
I mean, I'm just thinking on how to do the surgery. You kind of go from the side, and then like a camera, and do you have like it's like small mini hands in the endoscope there, and then this is how you kind of get it out and get it in?
Yes. It's endoscopically assisted, but sometimes you can also have direct vision to the valve. With this small incision from the right side is actually the direct trajectory to the aortic valve, and more you don't need to see more. It's just what you have to see, and you have a perfect vision usually to the aortic valve. And you implant this valve, we suture the new valve prosthesis in. There are other valves which actually don't need sutures anymore, but this is just a question of what type of valve you want to implant. Yeah, the valve is, we can take the valve out of the shelf, and this is how they look like if we have a valve to replace. So this is one prosthesis we usually use, and as I said, we can take the prosthesis out of the shelf to make a perfect fit for the patient.
Yeah. Okay. Thank you. Again, we have had this in different talks already. The recovery time is always the big question. How much downtime does a patient has to consider?
That is also depending on the patient itself. usually the aortic valve stenosis patients are a little bit older, meaning 60, 70 plus years. And of course, after surgery, they have a longer recovery time than younger patients. But usually with a small incision, mini thoracotomy, the pain is very minimal. So they don't have much pain. The first 2-3 days, they feel more fatigue. They're tired, but they really recover fast, and they ambulate after 2-3 days on the ward, and they leave the hospital after six days after surgery. Then, as we are, in Switzerland, and the system as itself is accommodated with rehabilitation possibilities. We send all the patients, if they want, to a cardiac rehabilitation facility after surgery. And they would go directly from the hospital after 6 days to the rehab facility for an additional 2-3 weeks.
Okay, so downtime 3 to 4 weeks.
Yes.
Okay. The other question that is important to the patients having an aortic valve surgery is the life expectancy. Can you comment on this one?
Yes, the life expectancy, as always, is depending on the patient itself. And in this regard, we have, of course, also to bear in mind that we have different types of aortic valve prosthesis to be implanted. A mechanical or a biological valve. And there's a difference between the two valves in handling. The life expectancy of a biological valve is not unlimited. Usually, we always say it's about 15 years mean, or more or less like that. So after 15 years, the patient has to, somehow get a second valve because the first valve has been deteriorated. This makes, of course, the patient having to come back and suffering a second intervention. But if they have a mechanical valve, for instance, a mechanical valve is the one from metal or carbon, whatever valve you take. But this valve, which is in need of a full anticoagulation, which has its downsides, of course, because if you have an accident or trauma, you bleed. This has also a morbidity in itself. So the valve itself has a long life expectancy. And the patients who has a mechanical valve, they usually, if they stick to the rules of anticoagulation, they have also pretty much the same life expectancy as normal people. But it's a valve implanted. It's something not normal people have. So I would consider the life expectancy a little less than without aortic valve prosthesis. But in general, the patients live a normal life. So they have no pain. They have no limitation to the performance. They can do whatever they want. But as I said, they have a valve implanted, and the valve has limitations.
Yeah. Okay. Good. Again, we don't want these interviews to be too long, so much appreciated that you're helping out here with some really inside expertise. Thank you, Professor Grünenfelder, and all the best. Thank you.
Thank you very much.